Good morning, good afternoon, good evening. Welcome, everybody. I'm just giving a moment to let everybody in. I hope you can hear me. If you can hear me, can anyone give me thumbs up so I know that I am audible? Okay, awesome. Thank you. Thank you so much. Thank you so much. Wow, so delighted to see everyone. Okay, thank you. Thank you. I see all the thumbs up. All right. Greetings, everyone. So excited to see you here. And thank you for taking a moment from your time to be here. My name is Chika Diamene, and I serve as the chair of the AfCOP Steering Committee, African Committee of Practice Steering Committee. It is my pleasure to welcome you to our first African Community of Practice webinar of 2026, right? We're delighted to have you back. Last year, we had a strong momentum as a community, heard from remarkable speakers across healthcare, quality and patient safety space, from global space even, not just from African speakers, but we heard from everyone. But one thing stood out to us. When we heard from colleagues and fellows doing the work within the continent of Africa, it felt especially meaningful and relevant. Following that conference, ISQua conference in Brazil, we also gathered together with the African community there, and we learned from them. We learned from the community what they want to do. It was a very wealthy conversation. That information was also brought back to the steering committee, and one message came through strongly that we want to hear from people doing the work. We want to promote the shared learning from boots on the ground, and we couldn't agree anymore. So, as a steering committee, we listened. So, we actually sent out a survey saying, okay, can we raise a one micro campaign? The truth is, in quality and safety, I feel like we all have our own individual nuances and issues, but for the most part, we all probably share the same theme. So, we said, let's raise a micro campaign. So, we put out information, a survey to our community to say, hey, out of these things, what would you want us to work on? Let's work on one thing, right, that is relevant to our space and improve it. And from that invitation, what came through was the learning safety culture. So we are working on raising awareness about this micro campaign about learning safety culture. And we want to hear from you. If you are doing the work, if you haven't started and want to start, we want to all work on it together. We are going to be at various stages with this journey. So if you are advanced, let's learn from you. If you're beginning, let's work together. So this is really a call to action to you. We are inviting you. You follow us on LinkedIn, send us emails, respond to the email from here, or just reach out to any one of the steering committee members. Let us know that you want to be part of this. You have something to share because we actually want to host a webinar with the people doing the work so that we could have this shared learning experience. So that brings me to our next version of today is really, I want to introduce our speaker. It is a privilege to introduce Dr. Elom Otchi, an organizational development, healthcare quality, patient safety, and health system consultant with experience working with international organizations, including UNDP, WHO, UNICEF, and Last Mile Health. He has worked across 10 countries, supported 5 in developing and implementing the national quality policies and strategies, helping strengthen governance, quality, and patient safety across health system. Elom serves as a technical director at the African Institute of Healthcare Quality, Safety, and Accreditation, where he leads initiatives to improve organizational performance and strengthen health workforce competency. Dr. Otchi is also an active researcher and ISQua Fellow certified hospital surveyor. He's contributed to developing the ISO 710 2023 and is currently an ISQua Lucian Leap Fellow for Patient Safety. Please join me in warmly welcoming Dr. Elom Otchi. Thank you. Elom, you're over to you.
Yeah, hello. Okay.
I can hear you. Oh, Elon, please let me just say this. If you do have questions as he speaks, please feel free to type it in. Once he has about 45 to 60 minutes to speak, when he's done, we'll have a Q&A session and we'll pull your questions from the chat box. And we may have the opportunity to to unmute and talk as well. So we'll see what works best. All right, over to you, Elon.
Thank you. Thank you very much to ISQua and to AfCOP for this opportunity. So I am sharing with us on this as much as possible. I will try to make it very interactive. If you have any thoughts, kindly feel free to share in the chat. So this is the outline. But I think before I proceed, maybe I am pulling this Menti out. If you can just, in 2 minutes, your brief description of what the patient safety situation on the continent or in your country is, what you think it is. You can just use this code, and then let's see what we come up with. Yeah. What do you think? What will be your description? Whatever patient safety means to you. The fastest fingers. I hope the code works when you go to the.
Elon, did you give us the link so that we could put in the code or just go to Mentimeter?
Oh, okay. Yeah, you just go to Mentimeter.
Okay.
Yeah, good. So we get the first one. Thank you. Any other thoughts? You can also post it in the chat. Uh, those of you who struggle with technology like me, you can use the chat. Good. Misconceptions, unsafe, costly to ignore, fragile. See it as opportunity, participation, left, okay, uh, improving in Ireland, okay, slowly growing, it's dire, okay, it's interesting. I would say patient safety awareness and regulations are just beginning in earnest in Nigeria, mainly at the national level. Benchmark and experience, thank you, implied. Okay. Someone I think would be okay. Okay, same as your country. Okay, thank you. Let's uh, okay, so please keep it coming. We'll come back to it. So this is what I think this is the former director for the Africa region. This is what he had to say, that there is no quality without safety, and no safety as well without quality. Um, For him, safety was at a virgin state in most of Africa, and it is difficult to prioritize patient safety action unless it is explained in terms of how it contributes to systems strengthening. And I wholeheartedly agree and associate myself with this statement. Let me proceed, I'll come back to that in a bit. So what is patient safety? And I picked this from the Global Patient Safety Action Plan, that it's a framework. All of these lengthy words create cultures, processes, procedures, behaviors, technologies, and environment in healthcare that consistently and sustainably lowers risk. So these are the outcomes. It should lower risk. It should reduce the occurrence of avoidable harm. And it should also make errors less likely to occur. In the instances where, or in the unfortunate situation where these errors occur, their impact should be reduced to the barest minimum. And I mean, we all know what Hippocrates had also to say, and he reduced it to some three words that we should do no harm as far as the patient is concerned. And I would share something on that in a bit. But as we proceed, I would like to say that when we discuss patient safety, and the concept of patient safety, we should look at it along all the dimensions of quality, because I believe that all the quality dimensions have implications on patient safety. Whether you are looking at timeliness, which has to do with the delay and the impact or the effect that the duration or how long it takes for us to provide care is concerned, or efficiency, which has to do with um, resource use or effectiveness, which has to do with outcomes, and how care is provided, whether we are adhering to the available protocols or standards, and equity, whether we discriminate or not, integration, the extent to which care is fragmented in most of our settings. You will have to go and get one service here and another service there. Care is not coordinated as much as possible. Or integrity, providing care devoid of corruption and collusion in a lot of settings. And then people-centeredness. This is what makes us human beings, in addition to being healthcare providers. In some settings, I mean, um, some of us and colleagues have been very callous when it comes to the provision of care. I visited, so I mean, I live in Ghana, but if I make or provide any examples, please don't assume they are Ghana. If I want to mention the country, I will mention it. But please, otherwise, don't assume, because fortunately, as the introduction mentioned, I have had the privilege to work in a lot of the countries on the continent. So that is just the disclaimer I want to provide. If I have to mention the name of a country, I will mention it. Probably that particular incident would be available in the media. So there wouldn't be any violations of all the MOAs that I have entangled myself with in my work. Thank you. Um, so I have three stories. One has to do with blood transfusion. And this, I was working in one of the countries on the continent. Two colleagues of mine plus three of mine and myself, making three. We had gone to this pediatric ward. As we walked through this pediatric ward, a little girl had in transfusion on. And as we were passing by, we saw this little girl shake on the bed, was shaking and was shaking very terribly. So quickly, one of the colleagues I was with was a pediatrician, or is a pediatrician. So he quickly stopped the flow of the blood. And then as he stopped the flow of the blood, the little girl received some respite. Now, quickly, we picked the blood. So as I talk, the healthcare providers in this particular ward were about 150, or no, were about 50 meters away from where the incident was happening at their desk. So as we quickly stopped the blood, we drew the attention of one of them, and then now they quickly rushed to the bedside. The first surprise for me was that the blood had no label. There was no label on the blood to even tell what type of the blood group, whether the blood had been cross-matched and whether the blood was compatible or not. There was nothing. This incident happened in 2019. So it is as recent as 2019, not 20 years ago or 50 years ago. As recent as 2019. So that was my first shock. The second was we took the blood to the second was we asked whether there was any whether there were any documentations of such incidents or any other than blood transfusion. The second was that the department or the ward didn't have anything like that. The third was we took the blood to the lab, and I was interested in following the blood to the lab. So we went to the lab. As we went to the lab, we checked, wanted to know what happened in such instances. Now, the other surprise was that there were no, there were no, the facility did not have the capability of doing any any testing to find out what went wrong and what the issues and what the challenges were, as far as or any investigations in the lab to ascertain all the issues. So that was the second shock, or the second surprise for me and for my colleagues. So we proceeded we proceeded. So we left. I mean, we had whatever discussions we will have with the department or the ward, and then our journey or our visit to that particular ward or that particular facility continued. The second story was or is has something to do with medication. So this was another department or another facility in another country. And I had the opportunity, was sitting at the pharmacy outpatient area. So as I sat in the pharmacy outpatient area, I observed two people. One woman, two women. One was very elderly. She will be in about her 50s. And then another was a young girl. This young girl should be about 7 or 8 years. So apparently the elderly woman was blind. This young girl apparently was the one who had brought this woman, who was a relation, to the hospital. So she had taken the woman through the registration process to the consulting room, and now it was time for them to get their medication and check out. So as they sat at the waiting area of the pharmacy, waiting to be served their medication, they had called and called and called, because I sat there for well about an hour and a half. So they had called and called and called. The pharmacy guys had cleared their plate of patients who were there who were supposed to be served. And they had not, so as I watched, when they call the little girl. When they call, there is no response, and then they push her card away. Then they call, no response, they push the card away. So at a point, I became curious, and I go to the pharmacy, and then I ask that why are they not calling these people or this little girl? And then they pulled the card and showed me the number of times they had called without any response. So I went to the little girl and asked the name of the mother. And then she mentioned, apparently that was the name on the card. What was surprising is the elderly woman was blind and she was deaf. So she was not hearing all the calls. It was the little girl who should do the hearing for her and who should be her aid. But she was also lost in the midst of the crowd. So they pulled her, served the medication, and I watched. The pharmacist or the pharmacy team in their cubicle will pull one medication. So this, you take this 1-3 times a day before food, then they give it to the little girl. This, you take it 2-3 times a day after food, they give it to the little girl. This, you take it in the evening before you sleep, they give it to the little girl. And I was wondering, then I asked them, are they seeing the state of the people they are dealing with? And then they asked, what am I talking about? Is it not a patient prescription they were serving? I said, yes, you are serving a patient prescription. But what shows that the information you are giving out is being received as intended? Are you seeing the patient? Are you seeing who has come with her? How are you going about ensuring that whatever you are saying is understood or understandable? I mean, and then the next question is, who are you? And that is to me. And every time I get that, isn't it? So I smiled. Who am I? It's not necessary. It's not relevant. So they continued. I told them, drew their attention that the woman they are talking to, the elderly woman, cannot see and cannot hear. So it's the little girl she came with. They have to try to make sure that whatever instructions they are giving goes through the little girl appropriately so that she can assist. I mean, that is another, the who are you did not make the conversation end well. My third story is from another country. This country, there was a brain surgery. In the brain surgery, the surgeons, the patient was rushed to the theater and they opened the patient's head up. As they opened the patient's head up, they started the procedure. And then as they were into the procedure, then the surgeons realized that this was not the patient whose head has to be opened. So they closed the patient's head up and then pushed the patient back to the ward. Then they started a search of which patient actually required the brain surgery. Every story I say is true. There is no, every story I say, whether irrespective of how weird, just that I will not mention names of countries. So these are 3 stories from 3 different places on the continent. I'm sure you will have your own story as you work or as you listen and follow the media. But these are statistics that abound. What is exciting or what is interesting is 50% of all of these incidents. Even some literature puts it at 80%. And in my own PhD thesis, it was about 85% of all the adverse events, about 4,000 plus medical records that was reviewed. About 80% plus of all the adverse events were preventable. So we can do a lot about it. The question is, what can we do and what do we do? So what is an adverse event? I say, and this is also from the Global Patient Safety Action Plan, that is an unintended injury, and it results in temporary or permanent disability. It will also result in a prolonged hospital stay and also result in the patient sustaining some life-threatening interventions, or it will also result in death. And what is important is that this is caused by healthcare management. So it is caused by you and I. It is not caused by the patient's underlying disease process. So these are some, I mean, a surgery, towels and stuffs were left in the patient's abdomen, and the patient had to come back for it to be removed. There was another incident as well in another country where a cannula was left in the left arm of a baby. This was about 6 months old baby. All of us went to sleep. The baby's arm got swollen, and I mean, before the baby left the facility, the baby's left arm up to the elbow had to be chopped off. So that is what it is. So what is it about reporting? Incident reporting, I say, is the process by which we, healthcare providers and patients, it is when we document and when we report these incidents or events that have the potential to cause harm or that have caused the harm to patients, through any safety system reporting that we have. This is some list of events, also from my PhD study. I mean, this was excavated from medical records. At the time in the study facility, there were no systems of reporting some of these events. A lot of the facilities and yeah, places that I have gone, facilities call them incident reports, but the incidents that are documented oftentimes not clinical or adverse events. They are maybe theft and I mean very those stuffs that nurses like documenting or writing, but nothing related to this. So if you want some of these adverse events, you will have to excavate the medical records of the patient yourself. But some facilities as well are doing well as far as reporting is concerned, and they have the list of incidents that or adverse events that have to be documented and reported. Now, the other bit is how timely we do our reports. So I was in this country where there was a surgical incident, and it had not been reported, it had not been documented anywhere. And this was after 1 week. And this even came up during a conversation and a visit to that particular surgical department. So the question is, what becomes the relevance of an incident if it is reported late? Zero lessons would have been learned. And I dare say that within the same period where the incident had not been reported, several others would also have occurred. So reporting will have to be timely, it will have to be accurate, and it will have to be very comprehensive and expansive, so that the necessary lessons and the things that we want to use it for, we can use it. The other bit I ask is, what are some of the approaches to incident reporting? I mean, as I go around, I learn and I see that we have reporting in some jurisdictions is mandatory, and in other jurisdictions is voluntary. So, I mean, we can have a discussion on what the pros and cons are for both sets or for both approaches. And then in other settings as well, they are using a manual and paper-based, and in other settings as well, it is electronic. So back to my mentee, I would like to know what approaches you are using if you are reporting incidents in your facility. Are these mandatory? What approaches are you using? Let me go back and see whether I can. Good. Let's see my next poll here. Um, so you can also contribute that in the chat if that works for you. What approaches do you use in your setting when it comes to incident reporting? Mandatory, voluntary? The mandatory reporting is compulsory. Whatever happens, you have to report, you have to document it, and the system is there. The voluntary is, I mean, semanfu. If you like, you report. If you don't like, you don't report. So let's see quickly. Okay, I see a few mandatory in the chat. Um, okay, okay. Looks like okay, mandatory, electronic, and manual. Okay. Okay, looks like lots of us have mandatory systems, but you can continue the poll there. Thank you. So the other question I ask is why we think it is important to report. And I think that as providers, it is a legal we have a legal and an ethical responsibility when it comes to healthcare and the service we are providing. So because of the legal imperative and the legal requirements and the ethical responsibilities we carry, we have to document and we have to report. It also facilitates early detection of patterns that you can tell at a glance. Like the slide I showed, the 2 or 3 slides I showed, you can tell what types of incidents or adverse events you are dealing with in your facility, which one is the most prevalent, and why are they occurring, and etc., so that you can make sense of the pattern and the trend. And it is only then that you can introduce appropriate measures to avert their occurrence. The other is it becomes a requirement, a regulatory requirement, and sometimes or oftentimes it is also an accreditation requirement. If you have a COSASA accreditation, it is imperative that you report every incident through the system. I think cookies. Jackie will correct me if I'm wrong. So it becomes imperative that you are reporting your adverse events. Um, Immediately it happens, you are reporting it into the cookies, and then you are studying. The cookies will give you the patterns and the trends, and it also enables you to do whatever analysis you would have to do. And I am sure other accreditation programs should be able to enable you to do that. Otherwise, some countries also they have their regulations, and the health regulations in those countries also makes reporting imperative. So you will have to do that and comply or ensure that you are compliant. For us in quality improvement or in the improvement science, it enables us to improve our care processes so that we put mechanisms in place. And that takes me to the next one, which is learning. So that we put mechanisms in place to avert a similar incident occurring. I mean, in all the stories that I provided, the surgical errors, this was not the last, or it was not the first surgical error in that particular facility. If you do a search, all the stories I have given will take you to the respective countries and the respective facilities, and you will know that it was not the first incident. For the medication bit I mentioned, it was not the first. And the blood transfusion bit that I also mentioned was not the first. There was another classical incident which also has happened, which is also not the first. In one facility, there was also a wrong leg surgery. They pushed the patient to the theater, cut the leg, only to realize that they have cut the wrong leg. So push the patient back and now are contemplating whether to cut the right leg. Now, if they cut the right leg, then the patient will be walking home without limbs. Meanwhile, the patient walked to the facility with limbs. So for us in improvement science, it enables us to learn and will enable us also to improve upon our care processes. So this is learning. This is patient safety learning. That is the process and practice that we providers and healthcare organizations, we seize the moment and we seize the opportunity to analyze and identify all the reported incidents. It enables us to identify all the underlying causes of the incidents and the adverse events. And it also enables us to implement strategies to avert future occurrences. Like I have said, for all those incidents, it has not been the last. So the question is, what have we learned, if we have learned anything at all? Or are we even learning? I don't remember the people in this picture, but this was one of the pictures I took in my many surgeons across across the country. If any of them are in, they can give me a thumbs up in the chat. So it will typically involve a root cause analysis, an FMEA, or any other problem-solving methods that we know as far as improvement science is concerned. If you are lucky, in a lot of the facilities, it's a lot of documentation and reporting going on, but this is not happening. So in one instance, you will see a recurrence of the same pattern of incidents repeatedly and repeatedly and repeatedly, it will tell you that this sitting around is not happening in most of those instances. So I want to ask, what is your number one challenge to adverse event or incident reporting in your facility or in your country? Again, the fastest fingers. Let me go back to my what's the biggest challenge? You can also drop it in the chat. Uh, Good. Can drop it in the chat. Good. Your number one obstacle or challenge to incident reporting. What do you think? What is it? If you have any challenge, what is it? What's So I have a few in the chat. Thank you. Keep it coming. I have 200 plus. So let's flood the word cloud. Workload, blame, fear, lack of knowledge, excuses, trust, professional, this secret or punitive culture, fear of punishment, fear of blame, no system of reporting. Okay, so the chat is also flooded. Cover-ups, facility image, lack of accountability. You are using all my words for me. Lack of accountability. Um, no clear structural guideline. Failure to evaluate effectiveness of the corrective actions. That's event reoccurring. Sometimes management fails to support. Uh, Poor analysis of previous incidents, underreporting, apprehension of leaders. Let's continue to flood the word cloud. Toxic leadership. I like that one. Whoever posted that, can you explain what toxic leadership is in the chat for us? Interesting. Nothing will happen. Nothing will happen. No system for report. I like nothing will happen. Uh, Reputation, attitude, self-defense, uh, toxic leadership, ignorance. Let's keep flooding the word cloud. Fear of repercussions. Okay, so I take everything you have said. So as if we were thinking alike. So I have one and two just to add to what you have as far as reporting is concerned and its challenges, everything you have said in addition to this too. And then the learning, everything you have said in addition to this. I think this is also a repetition. And these as well, time constraints, which is what you also have. Fear of the objective use of the data, which is also what you have. I mean, oftentimes why they say we should report is often not disclosed. And the big elephant in the room, isn't it? Culture. So let's see what's so I say, what is patient safety or a just culture? I think that and this is adapted reasons definition, that I say that a just culture or a patient safety culture is one where there is shared values. Whatever our values are is shared. Chika knows what my values are. I know what Chika's is. I know what Jackie's is, and etc. our beliefs are also shared and known. Our behaviors are also known, and it's very predictable. At any particular point in time, you know what Elom is going to do, what he will not do when he or she is confronted with ABC within our organization. And we also, patient safety is a priority. It is not one of the many things we do. It is top notch on our agenda. In this culture or in this environment, there is trust, there is openness. I am happy to bear up. I am happy to share. There is nothing to hide. There is no opaqueness as far as our practices is concerned. And there is continuous improvement. That is what we eat and drink. So every event, every incident is an opportunity to learn. It's an opportunity for us to ask all the why questions, so that we are able to put mechanisms in place to avert the next occurrence. And those who provide this information, they are encouraged. We don't call them chukes. We don't call them too known. We don't brand them. And we even reward them that if I report, I am rewarded, I am congratulated. I am not insulted as somebody who is the one giving colleagues up and all the things we say about such people. And these people are also clear about where the line is drawn between what is acceptable and what is unacceptable. So these are key. You can take note of some of the key items that is highlighted, and you can share your views, what the situation is, either in your country or in the care environment, where you are. There is no hiding of what is done, what has to be done, and what does not have to be done. So I say that a strong safety culture supports the reporting of incidents. It encourages learning, and it ensures that patient safety is consistently prioritized in all aspects of care. So a just culture is an accountable culture. It is not, we don't say because it was inadvertent, let it go. No, everybody is accountable. And this is from us, AfCOP. Chika already made mention of it in her introduction, so I will not belabor the point. So there are three behaviors to expect in any environment. One is human error. The second is what we call at-risk behavior. And the third is reckless behavior, like you are seeing. But I explain them in a bit. And there are also two schools of thought when it comes to error prevention. One is the perfectionist school, and the second is the punishment school. Those who believe in the perfectionist cohort believe that errors and adverse events will not occur if people try hard enough. So Chika did not try hard enough. That is why there was that medication altercation or the medication error. Jackie did not try hard enough. That was why there was the surgical error. And there's the thinking, and this thinking is based on the assumption that error-free performance can be attained if people are more vigilant. So shine your eyes, like my Nigerian colleagues will say, shine your eyes. When you shine your eyes, that error will not happen. When you shine your eyes, that adverse event will not happen. So whoever does not shine the eye, that becomes the reason why that right leg was chopped off. That has become the reason why. And there's another, there's another environment where a patient drove to the hospital for a cataract surgery. The patient drove his car himself to the hospital, was ushered into the theater and prepared for a cataract surgery. After the surgery, the medical team had to call the wife of the patient to come and pick him from the hospital because he was both eyes had gone blind. So maybe this surgeon or these team members did not do well enough. They did not open their eyes as far as these many incidents were concerned. So that is the perfectionist school of thought. Then there is the punishment school of thought. They believe that if healthcare workers who make mistakes are punished, fewer errors will occur in the future because they will be more careful tomorrow. When we punish you, when we sack you, when we insult you, when we blame you, when we chastise you, you will have a little sense in your coconut to know that next time you will be more vigilant as far as whatever you have to do is concerned. So what should one do in the event that any of these behaviors are displayed in your ward or in your department? One is if a human error occurs, and that is what we often say that what to err is human, isn't it? So it was inadvertent. Errors are often inadvertent. So when an error occurs, what should we do? When an error occurs, the literature proposes that we do one of four things, or all of these four things. One is that we should look at our procedures and either reset our procedures, our processes. We can also correct human errors by training and designing or redesigning our workflows, our work processes, our procedures, and etc. So this is one of four things that we can do in the event of a human error. The other is the at-risk behaviors. These at-risk guys are gamblers, isn't it? I mean, in Ghana and in one of the balances, we say that it's like cha-cha or doing lotto, gambling. So it's like this is our standard. This is what we do. But you will come and say that, no, this is another way of doing it. If it works, we will clap for you as being an innovator, or we will clap for your creativity. But if it doesn't work, I mean, then it becomes problematic. So these people, we guide them to ensure that as often as possible, we increase, or they should increase, their situational awareness, because there might be one thing or some things around their environment that they might be ignoring. So they should be up as far as their situational awareness is concerned. The other is that as healthcare organizations, we should be able to remove all incentives for at-risk behaviors. If you look at aviation, they have tried to do that, and they do that by what we call a human factor engineering. So we should be able to do that. I often say that sometimes they design the system to, I call it idiot proofing. The system is idiot proof, such that if you even put the most dumbest person in the system, it will be extremely difficult for the system, for the person to create or for an error to happen as far as that particular setting is concerned. So I propose, and that's what I often say, that I propose that for you to deal with at-risk behaviors, you should design your system so that it is idiot-proof. Once it is idiot-proof, you are guaranteed. There was one country that said that their constitution was so robust that it will be impossible, or it will take a miracle for a certain president in the world to emerge as a candidate, let alone to emerge as a president. So I will not mention the names of the country and what president they were referring to. But I feel that that is one way of removing the incentives for at-risk behaviors, developing idiot-proof systems. And then the other is creating incentives for healthy behaviors where we are rewarding when necessary. And then the other type of behavior is the reckless or deliberate behavior. These people, we manage through remedial action, or we punish. We should be able to punish them. They shouldn't be hiding behind to err is human and be committing all the errors and blunders as far as our settings are concerned. So this is a summary that I say for human error, we should console, because to err is human. We can see that it was the frailties, and this is what somebody said. I was watching a video on some of these events, And it says one was an orthopedic surgeon who told his orthopedic residents that sometimes it becomes inevitable. But when the inevitable happens, as a provider, you should have the courage to call the relatives to the table, look in their face, eyeball to eyeball, and tell them that I did my best. And you should also be able to console your team, knowing that you truly did your best, but it was inevitable. So for human error, you console. For at-risk behaviors, you coach and guide and direct. And then for reckless behaviors, you punish. Let's deal with them as far as the occurrences are concerned. So I summarize this in a general principle that when dealing with these situations, we should console we should console the human error. We should coach the at-risk behavior, and then we should punish the reckless behavior. It shouldn't be hiding behind to err is human and be doing some of the things that we do. So what should our safety aim as a healthcare organization be? So I say that our safety aim should be, we should aim at achieving an error-tolerant system. What do I mean by an error-tolerant system? I mean that this is a system that is designed to have the capability of averting or reducing the risk of translating errors to harm. It should be able to catch it before it happens. And these are the reasons safeguards. We should be able to have so many safeguards as far as our processes and procedures are concerned, so that we catch it before it finally lands on the patient. Um, what do I have here? I say some barriers to establishing a patient safety or a just culture. All of these things will not enable us to get the patient safety outcome that we desire. Some of us are full of ego. I mean, our ego is like the Atlantic Ocean, very full. When we are walking, we can't even lift our heads, full of ego. We are full of ourselves. There is no humility in us. A lot of these incidents and events, a little humility could avert all of them. Instances where providers have asked their colleagues, do you know which school I studied? Do you know how long it has taken me to earn my degree? And what has it resulted in? The patient dies because of a just simple act of humility would have saved a lot of the patients you and I have killed, and you and I continue to kill. So ego and lack of humility, and then fragmentation of our health systems, and then our thinking as providers. We think in parts that when we get the patient at the emergency, we think, oh, it is only us who are managing the patient. We don't think that from us, the patient is moving to another setting. So the systems concept is your output becomes another person's input. Your output becomes another person's input. So we should be able to be appreciating the chain and the interlinkages as far as patient care is concerned. And the trust issues, most of them, you mentioned them in the word cloud. Leadership and the issues of resistance to change. That as for me, this is how I do it, and this is how it shall forever be, even when times are changing. So I'm about ending. I share 3 implications of patient safety we should know as healthcare organizations. That one is the legal implication for us. 2 is the ethical implication, and then 3 is the financial implication. So what's the legal implication? The WHO has developed this document, which is the Patient Safety Rights Charter. In these 10 patient safety rights are identified. So patients have a right, and they have a right to what's the 4th one? Safe medical products and their safe rational use, safe and secured healthcare facilities, and all the others. So we cannot it is not, it shouldn't be business as usual. It should not be business as usual. We are not doing them a favor. So, and I say that inevitable harm today, what you are thinking is inevitable harm today. Tomorrow has the likelihood of becoming what labeled as gross negligence. So we better we better be careful. If you look at the Universal Declarations on Human Rights, health is also a human right. And every person is guaranteed the highest attainable standard of physical and mental health. So we are not doing anybody a favor. Once you have those stethoscopes hanged around your neck, or you sit behind the microscope, or you have the privilege of counting or deciding which medicines are taken by who, or whatever your role is in the healthcare team, you are not doing anybody a right. You are not doing anybody a favor. It is a responsibility you owe, and you have a legal imperative to ensure that nobody is harmed in your care. The ethical implications are these ethical principles, which I believe we all know and are familiar with, that our practices and the care we provide have to be beneficial to the patient. At any point in time, we are counting the cost, weighing the cost against the benefit, because the patient is trusting us with his life or her life, that we should make sure that we are not doing harm, which is non-maleficence, to the patient, and we should respect them. Oftentimes, we think that patients don't know anything. So you have come, so sit down and let me take your blood. Or you have come, so bring your bottles and let me give you an injection. We will not provide any information. There is absolutely no respect for the patient's autonomy or the patient's independence. We think that it is we who are knowledgeable as far as our practice is concerned. But the question I often ask is this, that for a patient who has lived with diabetes all her life, and I see a lot of them, this person is about 80 years plus, and she has lived with diabetes for 80 years. What makes you think that your study of diabetology, or whatever you want to call it, for 20 years, even if you are a consultant, what makes you think that all the knowledge you will gather from the book is superior to the lived condition of this patient, that you will not respect her when she says that this is not how I take my insulin, or this is not the brand, this brand does not work for me. And you are going to push what you have learned from textbook, not even from any well-researched paper, but what you have read from an ancient textbook, which is totally outdated. So respect and consent is an integral part of respect. So both verbal consent and written consent is very key. If the patient cannot provide it, talk to the next of kin, or talk to his or her relation, in the event that the patient does not have the capacity to provide consent. And our various documents, or our various legal pieces of document in our respective countries, I'm sure addresses a lot of this. And this also goes back to the legal implications and justice, that we should be fair. We should stop discriminating as far as the provision of care is concerned. So we owe this, so long as we are in this profession, and this is what we will do for the rest of the time, for the rest of our lives. This is owned. We are not doing anybody a favor. So let's stop thinking that it's a privilege we are giving our patients. The other is the financial implications, and I call this the business case for patient safety. And there is a whole lot of discussions we can have on each of these individual implications. And we all know patient safety incidents leads to prolonged hospitalization. You saw that in the definition of an adverse event. Additional treatment, cost of litigation, And often I have a lot of lawyer friends, but I mean, litigation is like, they say when two lawyers are fighting and there is a cow that is in between, and both of them have their cups, and they are milking the cow, and each of them are taking their portions of the milk away. But um, but litigation has a cost. I was advising my student yesterday that whatever it is, don't go to court as a practice. No, um don't go to your regulator as a practitioner. For whatever it is, make sure you guard against being summoned by your regulator. And why do I say that? Your regulator will not take away, your regulator will take away your license, but the court oftentimes will hardly take away your license. So aside the financial cost to you, the practitioner, and even sometimes to the provider, there is also the economic cost of fatigue and the walk around and etc. And there also the cost of image. Now, when you Google uh, wrong side surgery, you will see the hospitals that you will get, and all of these are image issues to the facilities. And facilities have paid millions of dollars, millions of Ghana cedis, millions of rand, as far as cost is concerned. And all of these costs could have been diverted to improve the outcomes of care. This is my last slide, but I will do this as the last one. So what can we do? One is that we should implement accountable health systems. And this is the proposition. And I published this paper with Professor Greenfield. And what we mean by an accountable health system is defined in the paper, that we should focus on person-centered care or people-centered care. We should be human beings again as healthcare providers. We should be kind again. And we should also establish and implement healthcare governance systems. There should be proper governance arrangement. Who is appointed to do what, with clearly defined roles and responsibilities. And we should also be able to measure for accountability, set our KPIs and measure and establish and maintain the management of our required infrastructure, and then issues of capacity building and our ability to understand, delineate stakeholder roles and responsibilities. And we also say that there should be appropriate and adequate funding or financing and resourcing as far as our health care systems or facilities are concerned. We believe that if we do all of this, it should lead to improved accountability as far as quality and safety of our healthcare systems are concerned. The second proposition I make is also a paper that I have just done, a perspective I have just done with my colleague in South Africa, Professor Tenza Sabilele, and another colleague in Ghana. And we propose the use of this patient safety framework, that we say there should be a legal framework for patient safety. I mean, all of our countries on the continent, we don't have any proper legal arrangement or patient safety laws. I know somebody will say we have a patient safety law, but if you have a document that has the name patient safety law, it does not make it a patient safety law. So I mean, none of what we have will pass as a patient safety law. So we should develop proper legal frameworks and legislations that makes it possible for healthcare providers to be open and transparent in the event that an adverse event occurs. They can document it so that whenever they analyze it and there is disclosures, patients will not use those disclosures as evidence against them in the court of law. And I mean, all popular national quality and patient safety policies and strategies. I mean, I also did some work with colleagues in the WHO. We compared countries that have this NQPS and countries which did not have. And we saw that countries which had NQPS, even though most of them are struggling with implementation, are doing well than countries which do not have. So, I mean, it's important that if we don't have NQPSs, we are able to develop them, and there is a clear strategy for patient safety in those documents. Regulation. And in regulation, I propose that our regulatory bodies should be more proactive when it comes to doing what is right. Oftentimes, regulatory bodies are laid back, and it is only when the event has happened, then they start chasing and going around. But we need regulatory bodies that are more proactive, that are searching and ensuring that healthcare facilities are safe for us to use, other than regulatory bodies who are only interested in collecting fees and charges from providers at the end of the year in the name of registration. And patient safety culture, we have had a lengthy discussion on that. Moral and ethical implications of patient safety. Here, I propose the implementation of the 10 commandments of patient safety. When you do a Google of the 10 commandments of patient safety, you will see what I propose with my name. It was a blog I did and shared in one of the ISQua papers. So that is the proposition. And humble health systems and healthcare providers who will be able to plainly admit that we got it wrong this time and are happy to apologize to victims as far as our flaws are concerned. And we need an empowered patient, not only an informed patient, an empowered patient who can also call the health system to order as far as its doings and practices are concerned. And then finally, I say that I have talked about this already, that it's one big whole. So don't just say that you are doing patient safety. All the dimensions of quality will speak to patient safety, and they are interrelated. So I conclude by this Angelo. He says she has learned that, and I have also learned that people will forget what you said. People will forget what you did, but people will never forget how you made them feel. The second is from Donabidin. And I also love this quote from him that the secret of quality is love. You have to love your patient. You have to love your profession. And finally, I know that because I am speaking to a lot of Africans who are very religious, you have to love your God. And my last quote, I was attending a meeting somewhere and they asked me to submit my favorite UI quote. And I sent them this and they said I should change it. I said, why should I change it? This is my favorite of all my quotes. That insanity is doing the same thing over and over again and expecting different results. So my African health colleagues and my Africa colleagues and other colleagues on the call, if we don't change, we are insane. And simply, insanity is madness. So if we don't change, and you and I continue on this tangent as we are going, irrespective of all the resources we have received and all the funding we continue to receive daily, if we don't change, then me and you, let me use broken English here, me and you, if we don't change, then we are insane. We are mad. I hope nobody will accuse me because I am quoting Albert Einstein. Thank you very much. Let me finally end with this, inviting all of us to Chennai, Kaho. So all the Kaho colleagues and India colleagues. So thank you very much, Chika. All yours.
Oh my God, Elom, that was exceptional, brilliant. And I can tell by the engagement, I have been enjoying the chats. You have not had that luxury. It is active and people are sharing, asking important questions. And may I say this? I think we are insane. Let's just say that we are. Because we've been on this quality journey for a very long time, and some of us have progressed. But sometimes I often wonder, why do we all have falls as a quality goal every year? as if it's a recycled, we're playing a musical chair. If we didn't improve it last year, we just do it again next year. Or infection prevention, right? We continue to recycle the same goals over again. So that means we keep doing the same things, somehow expecting a different result. And that's why the goals, they keep showing up on our metric, on our goal. I would say this, that this has been an engaging topic, and I'm glad that AfCOP chose this as, and I'm glad that you gave this really a foundational talk to us about the learning culture and system, the system, the safety culture and learning system. The reason for that is from the chat, I am noticing that we all share the same problems. And just don't even think it's just from even at the continent of Africa. I think it's really globally because some people that are not from the African countries are also speaking to their issues. And it seems like it's a shared issue across the board. So, and thank you all of you that have put in some ideas in the chat for other people to learn from. We're going to move into the Q&A session, and I have one question in the Q&A session, and I see another one in the chat. So, Elom, are you ready in the next 15 minutes or so? We'll use it
Yes,
to
yes.
interact with some of the
We'll do our
questions.
best.
We'll do our best. Okay. The first question I have here, it says, is there any analysis of the financial costs or non-quality of adverse events in Africa? What is the impact? Should I repeat
Yeah,
that question?
so I
Mhm.
I think this will be a very interesting area to explore because if you look at the literature on the cost of quality or the cost of patient safety, a lot of the literature is from Europe and the advanced countries. You don't see a lot of documentation and publication of this important area of work in our part of the world. So it will be an interesting area to explore as far as the work in this area is concerned. Yeah, that's what I will say. We don't have a lot here other than media publications from the BBC and our various um, country media houses. Yeah, and some documented reports. Other than that, you don't have a lot of published literature in published peer-reviewed journals.
Thank you. Thank you, Elum. There's a question from the chat, and I'll move back into the Q&A session. It says, is patient safety achievable in Ghana, considering the logistics and the human resource gap in the country? So please answer away because I'm all ears. I
Yes,
want
I
to
mean,
hear this
yes,
too.
it is. I mean, what is not everything is achievable. There's this and one of the publications that often move me is the bundle in the that's by Peter Pronovost. I've forgotten the title of that paper where they introduced a bundle, and there was, I mean, for all the improvement we do, that gives us evidence of improved outcomes. It should tell us that everything is achievable. So it is achievable. We have to avert our minds to that. We have to do what we have to do as far as implementing the things we have to implement is concerned. But a lot of the facilities, governance is virtually non-existent. People are appointed without any merit. So what do you expect? You cannot, that is why I go back to Einstein. That is just repeatedly doing the same things over and over again. And it has become some comfort zone. So, and change is very difficult. So everybody has become accustomed to it. All of us know that the medical director doesn't know there, but we are all happy he has been appointed. All of us know the CEO doesn't know there, but we are all happy he has been appointed. And most of us in our part of this country, some of these public offices are rewards for political parties, not necessarily competence. So that is our problem. And if you read the paper on accountability, that paper addresses and makes those propositions that were shared. So until we do what is right, I mean, we shouldn't expect any transformative or second order change in our health systems. It will just be pouring water in a leaky basket. every year by our donors and international partners. And they will think we don't even know what we are about. Unfortunately, when you sit in some of those meetings, that is what it is, and that is what it looks like. Because you read some of our reports and you can't believe that these are coming from colleagues who have actually gone to school and are supposed to be able to do what is right. So it is achievable. Everything is achievable. Over.
Thank you, Elom. So another question says, what is a healthcare accreditation standard in Africa?
I mean, so accreditation standard, I don't think we have a unified accreditation standard or a unified accreditation board. I work with, or I support this, the Africa Regional Standard Organization, ASO. So they are trying to do something as far as healthcare standards and accreditation on the continent is concerned. And these are supposed to be implemented by country ISO or country standards authorities. But the uptake has also been slow. I think one of the countries that has been doing well in the region when it comes to ASO is the Kenya Standards Bureau or the Kenya Standards Authority, because I think they are the only country currently that have even nationalized the ISO 71001 quality management standards that is being implemented. Recently, the Ghana Standards Authority also adopted it, and they are yet to also publicize it. So we are not doing well. Other than that, the other body is COSASA, isn't it? And COSASA is private, and it is also doing their bit also across the continent. So I believe that we need that synergy as a continent. And I think that is a vacuum and a role that AfCOP should consider taking up as far as the quality work is concerned, because CAHO is doing that in India, in that particular region. So I feel AfCOP, it's a very important role and a very important gap. Fortunately, Jackie, with her knowledge in accreditation, and a few others with their knowledge in accreditation and standards, can support the process. If for nothing at all, we have plenty standards. The ISO standard is there. That is universal. That one, there's no cost. There is cost to it, but there's not a lot of politics around it like the other private standards. But COSASA is also around. That has also had a lot of uptake across the continent. So if for nothing at all, we can start with this and then get something universal for the continent and support WAHO and the other African health bodies as far as this is concerned. So I throw that back to us as a challenge to AfCOP and all the colleagues to consider looking at it and supporting the process. Thank you.
Thank you, Elom. The questions are coming in. So this one says, many hospitals collect incident reports. I can't wait for your answer for this, but struggle to translate them into the system level improvement. What governance structures or processes have you seen work effectively in African health system to ensure that incident data leads to measurable safety improvement?
Look, so I think that, you see, indicators are good, but it is what is important and relevant at a time. Other than that, you will spend a lot of money collecting the data and it becomes virtually less useful. So I think let us start with a bit at a time. It's a bit at a time, because I go to other facilities, they also have a system for collecting, for instance, patient complaints. At the end of the month, they print a tall list of complaints, and you don't even know where to start from as far as addressing them is concerned. Yeah. So we need very simple set of indicators at any particular point in time. If it is patient safety incident, what particular, maybe top 3. That is why you do the analysis. The frequency. So top 3, top 5. It is very minimal. Then you put the mechanisms in place, and oftentimes those measures are replicable so that you don't even have to reinvent the wheel. But a lot of us are collecting virtually everything. And at the end of the day, it leads to nothing. And it becomes a waste of time for the precious provider who is collecting the data, and also is not also receiving any feedback. So that for me is my thought on that.
Thank you, Alan, for that. And I agree with you that just minimizing and focusing priorities, select your priority areas and focus on that. But more importantly, giving feedback to the people who are reporting, because that also encourages more reporting, that learning culture that we're trying to establish. The next question says, as we have National Accreditation Board for hospitals and healthcare providers in India, who is the accreditation agency? Um, I suppose in the continent of Africa.
Yeah, so that is another that is another thing that I think should also be, is it a second or a third challenge for us as AfCOP? And see how we do that. But like I mentioned, the Africa Regional Standards Organization, ASO, that is, but it is virtually. I think they can do more, and maybe we can collaborate with them. But I think there is a huge gap in that. So we can add that as part of our menu list, Chika, uh, because I don't think we have that anywhere on the continent. Maybe some countries will have who are pursue, yeah, but even for a lot of the countries, there are state agencies, like in Ghana is our Health Facilities Regulatory Agency, that is responsible. But I mean, other than that, when it comes to accreditation, that is another different ball game. And yeah, so I think it's an area for us to look at. And the interesting bit is a lot of countries don't even also have anything as far as regulation is concerned. So I think it's an interesting area for us to look at. So that is the second or um the third thing we can put in the parking lot for AfCOP.
Thank you. And I think we also have an opportunity to learn from continents, all countries that have done this, have been able to establish a regulatory body. I remember when the Air is Human came out, it took the United States almost 10 years to implement, and it was regulation that actually enforced patient safety systems and organizations. So learning from that to recognize that most individual organizations are not just going to take this upon themselves. Sometimes it's probably going to require that centralized regulation to enforce the processes. All right, we have 2 minutes. This question is said, what are some practical ways to improve accountability without killing the reporting culture? Over.
I mean, it's one, I think, should be encouragement. Two should be standards, so that it removes every form of bias. It makes all of us objective as
Yeah.
far as the application of the rules are concerned. And then three, I think, should be capacity building. Capacity building in understanding what accountability is. Capacity building in knowing what our roles and responsibilities are. Capacity building in appreciating what the implications are as far as all of these things are concerned. So that will be my very brief answer. I hope I have tried.
You have. These questions are tough, and you're doing excellent. One more. We have more, but let's take one more for the sake of time. So, how do we cultivate the accountability culture in our public hospitals? As lack of it is the biggest challenge, and I agree.
This person wants to put me into trouble.
Love, you're scratching
So
your head. Okay,
So
please.
in short, I will refer the person to read the paper that I wrote with Professor Greenfield, on accountability. It's free and open access. So you can just do a Google and download it and read. so that you don't put me into trouble.
You've been
Thank you.
giving reference to read. There you go. All right. Elom, this has been amazing. Thank you for starting this journey for 2026 for us with this amazing presentation, one that is relevant to every single person who came here today, I can tell, and one that is relevant even for those who are going to listen to this. So thank you for the delivery, the coordinated way that you, and then the way you engaged us with questions. I took pictures of all the, so please share that within the group because I think the responses we got from the pool, I think they're going to be useful for our future work. And
Yeah, definitely.
thank you, everybody, for taking your time to be here and share this moment with us. Thank you for encouraging us to continue to push forth. Sometimes we feed off of your energy. You being here, you taking the time reminds us that this is important work and we should keep going and we should keep making effort. And please continue to work alongside us because we want to all co-create this journey. Thank you all and have a wonderful rest of your day. Elom, thank you
Thank you, and
again. And
Happy
it's
New Year
quiet.
to everyone.
Happy New in March. ISQua, we always appreciate you for your support of this journey. Thank you, everyone. Bye bye.
Definitely. Thank you. Bye.